at Adelphi University, at the School of Nursing, I believe, or the School of Pharmacology, or whatever. And he knows all about these medications. And let me tell you, this is a big job. Lots of medication errors can be made. We have to avoid them in a hospital. We have to avoid them in our home. Alex is going to tell us all about that.
Okay, thank you. I'm not sure how much you really know about hospital pharmacies, so we're a little bit different than your local community pharmacy, though the hospital actually does now have a community or retail pharmacy in the lobby. So if you ever get to the lobby of the hospital, we're tucked away in the corner by the gift shop. It's basically there to help people who are discharged, who go to the ED, get their medication so that they can go home without having to go out to the local pharmacy. The main pharmacy in the hospital serves all 535 patients plus the emergency room. We have about 90 to 95 pharmacists, technicians, and other staff in the pharmacy. We are highly automated. If we have a few minutes after I speak, I have about a 2-minute video that'll show you the robots that actually run most of the pharmacy. We're trying to automate everything so that we can reduce the possibilities of medication errors. The hospital pharmacy is about 4 or 5 years old. We have the most highly automated pharmacy in the entire tri-state area. The hospital's made a tremendous commitment to reducing medication errors because we have thousands and thousands of drugs. We also have a CDC approved clean room that we use for making all IVs. So it's completely different than what you may have been exposed to in a local setting. I'm going to talk to you a little bit today about some of the new drugs that are on the market, and while I'm at it, I'll be talking to you about some common advice about what you should be doing as an educated consumer, because medicine and healthcare has changed drastically over the last 10 or 15 years, which I'm sure you're all aware of. Okay, let's see. Okay, everybody knows about the anticoagulants, and probably most of you know about Coumadin, right? Warfarin and Coumadin. That's the anticoagulant that most people have had experiences with for years. It's been around for 50 years. It's had a long history, clinical experience. It's easy to see how it works. You can do a test. The testing is relatively simple. You can manage the bleeding very well because all you have to do is give vitamin K. Vitamin K is the antidote for Coumadin. There's no kidney function reduction in dose that you need to do, and it's relatively inexpensive as drugs go nowadays. Now, there have been a lot of products that have come out recently. They're now called the direct oral acting anticoagulants, and some of the products out there that some of you might actually be already on. Pradaxa, Eliquis, Xarelto, Saveza, and Bavexa. These, they do have advantages, there's no doubt about that. These are the new drugs. They're far more effective than Coumadin in preventing strokes. They're fixed doses, and you don't need to do all these monthly tests to do get the levels and everything. There's no dietary restrictions. One of the biggest problems with Coumadin always was you had to be so careful about what you ate, particularly if you were into green leafy vegetables, spinach, any of the kale, any of these products that a lot of people eat were high in vitamin K, and vitamin K would completely antagonize the effects of Coumadin. Well, these products don't have those issues. They have very rapid onset, a couple of hours. You know, somebody presents to the emergency room and they're at risk for stroke. You give them one of these drugs and you reduce that risk very quickly. With something like Coumadin, you had to wait 3 or 4 days. You most likely would put them on heparin intravenously while you were waiting for the Coumadin to work. The problem with these drugs is they don't really have reversal agents. In other words, they don't have antidotes. 1 or 2 of them recently just came out with antidotes. These antidotes are incredibly costly. One just came out in November called Andexxa. The lowest dose for Andexxa costs $24,000. And that's the lowest dose. If you're a larger person, it could go as high as $50,000 to reverse a dose. So it's incredible. So there's pluses and minuses. So and hopefully you don't need to use those products that often, but you can understand why there's still a lot of people who want to stay on Coumadin because Coumadin has been well managed. Doctors know about Coumadin. It's easy to reverse Coumadin with vitamin K. So there are new products. They have some advantages, but sometimes if they overshoot the mark, trying to reverse them is extremely difficult. In fact, 2 of them, there's no antidotes for at all. You have to start giving a lot of blood products, which again creates a lot of other issues. Now, for psoriasis, most people who have psoriasis, they're used to using creams, and years ago you had tar products, you had all sorts of stuff. Now you've got these new biological drugs, Humira, Enbrel. These have an anti-inflammatory action on the immune system. They're all injectable. Some of them are self-injection. They come in the form of a pen. They're extremely costly. Humira is about $3,000 or $4,000 a dose, once a month. But they do have some serious side effects, and they're really only for people who cannot manage the psoriasis, who've got very, very severe psoriasis, which really cannot be managed with usual therapy. Because they do have rare but very serious side effects. Some of them have fungal infections, increase your possibility of getting malignancy, possible tuberculosis, heart failure. They should not be used in anybody who has an existing infection or who has a compromised immune system. So what does that mean? Well, a compromised immune system is obviously anybody who has AIDS or HIV disease, but it could also include anybody who's being treated for cancer, because anybody who's treated for cancer could also have a compromised immune system, at least for that treatment period. So while these drugs are revolutionizing some of the treatment, they are not for everybody. You may be seeing commercials for these things on TV. I mean, I'm sure several of you have seen them. They're not heavily advertising some of the rare side effects, but some of these side effects, even if they're rare, they may be catastrophic for some people. Now, shingles. That's not necessarily so unusual. There's probably a lot of people in this room who've already experienced shingles. I've had shingles. The zoster vaccine was the only choice for shingles up till quite a while ago, Zostavax. There's a new product out called Shingrix. It requires 2 doses, 2 to 6 months apart, and it's far more effective than Zostavax was. That being said, and the fact that it's not a live vaccine, so you could use it in patients who have immunocompromised, HIV patients, cancer patients, so it's safe to use in those populations. It definitely has a much better length of action. I mean, I think Zostavax is good for about 2/3 of patients. The Shingrix is far more effective. The biggest problem is it got so popular that the company can't produce enough of it. So what happens is people get the first dose and then they can't find the second dose. And now I get people calling me up all the time, do you have Shingrix, because I need a second dose. And I've been looking for it all over the place. So the company's really trying to ramp up production, but it's almost that the success of their product has killed them. So they're getting there, but they really, I mean, it is far better than Zostavax, and it is something that you can use if you even had the shingles. So now in diabetes, I'd say there's been some really new technology with the insulin preps. They're all basically in pen-like delivery devices, because pen-type devices are much better for the home person to deliver. They're not good for the hospital. We don't use insulin pens in the hospital because there have been too many instances where insulin pens have been shared between patients, and that really presents an infection control issue. But if you're at home, the best thing for you to get an accurate dose is to use an insulin pen device. Now what's happening in the industry, Most of you know what the term generic means, right? There's a brand name for a drug, and when the patent runs out, other companies make it, and they make it under the name of generic brand, and it's usually less expensive. Now that's for a chemically similar product. Now these products are biological products. They're not chemical products. So a biological product where the patent runs out, they can't call them generic, so they came up with a new word. I guess we're really good at that, right? So they came up with a new word, and the word now is biosimilar. So biosimilar is the equivalent of generic for a non-chemical drug. I don't know if you got that. But that's the new term. So if you hear the term biosimilar, it's the same thing as really almost generic, except it's like a generic for a biological product. And obviously there are some cost savings involved with that. There's a new class of drugs over the last 5 years called the sodium glucose cotransporter 2 inhibitors. Real long chemical name. What it really means is these products block you from absorbing sucrose and sugars. They can actually block you from absorbing about the equivalent of 240 grams of sugar a day. That's about the amount of sugar in a 12-ounce can of Coke. And I've been told by my physician that because I liked Coke, and I was told I needed to lose some weight because I have metabolic syndrome, I'm pre-diabetic. So he said, why don't you try one of these things? And then the plus is, if you stop absorbing all this glucose, you might lose about ½ pound a week. So I tried it. Well, I could tell you about the side effects of these products. It took only about 7 days to really knock me out. It created, all this glucose has to go someplace. So it goes into your bladder and created like a total osmotic diuresis. Let me tell you, I thought I was losing total control over everything. And on top of it, because it's all this sugar in the urine, it makes you more susceptible to urine infections and fungal infections. So it may not be for everybody, but it's something to consider. They have some very positive effects if you're a diabetic with cardiovascular disease, but they definitely didn't work for me. And one of the things I would advise people while you're at it, these are not inexpensive drugs. A 30-day supply of one of these is about $700 or $800 a month if you had to pay for it. Now he gave me a 1 week supply of samples, and I didn't even get through that 1 week supply. So if you're going to be introduced to a new drug that you're not sure that you're actually going to be able to handle that well, I would suggest you start out with either, ask him if he's got some samples, or start out with a very small supply, because nobody can take the drugs back. It's really against the law to take any medication back. Now in Parkinson's disease, levodopa and carbidopa were the drugs that have been around for 30, 40, 50 years. The problem with these drugs are they're very short-acting. You practically, if you have a very serious Parkinson's disease, you practically have to take these drugs almost every 3 hours around the clock. So the advantage of this new drug, sulfonamide, is you only take it once a day, which is phenomenal. The other part is you don't have those gaps where you have time off. The common side effects, though, have to be balanced against that. Sometimes you have involuntary movements. It's definitely a problem if you have elevated blood pressure, so your blood pressure has to be checked periodically. You've got to be very careful with some of the foods that you eat. We're talking about foods high in tyramine. Now tyramine may just be a chemical to some of you, but what's high in tyramine? Aged cheese, aged or anything fermented, cured, or pickled. That's a lot of stuff that we all like, right? So those are all things that you would have to avoid if you were taking this product, because that would cause a very serious increase in blood pressure. And it's a very unique side effect with this product. It causes what's called sleep attacks. Now, a sleep attack is a sudden falling of asleep without warning during normal activity. It's almost like narcolepsy, but it's not the same. Narcolepsy is more predictable. Now, influenza. Everybody should be vaccinated against influenza. There's absolutely no excuse for not being vaccinated against influenza. Used to be that people who had a true egg allergy, but even in this age now, most influenza, there's an influenza vaccine that is not based on egg allergies. So patients at risk, anybody above age 6 months through 5 years, and there's really no excuse for it. I mean, the hospital has reacted to this. I mean, essentially, every single hospital employee has to be vaccinated. We were told that, yes, you may have a religious or a personal, you don't want to be vaccinated. Well, you're going to walk around with a mask all day long while you work. And that was the only choice for all the employees in a hospital, because not only are you a possible threat to your coworkers, you're a threat to the patient and anybody else. So I think we actually got close to something like 99% in terms of vaccination. This is the new guideline. The Board of Health is playing hardball now. They're not accepting the fact that people are not willing to be vaccinated. I know we're living in an era where there are people who choose not to vaccinate their children, and you read these horror stories about, all of a sudden now we have, these outbreaks of diseases that we thought we had conquered years ago. I'm waiting for the first, outbreak of polio to come back at this point now, because people are not vaccinating. And it's really going to become a threat to the public good. Now, let's talk about managing pain. We're in an era right now where the United States is going through an opiate epidemic. And it's unique to the United States. This is not happening in Europe. It's not happening in any other parts of the world. It's unique to us. This has basically been going on for about 20 years. It's slowly starting to abate. And we really have to figure out a way to control this. In the hospital, we're mandated now to start looking at different ways to treat pain. The first thing that we're looking at is, the hospital just had its major inspection about 10 days ago. We have a major accreditation inspection with the government, or CMS, every 3 years. They were here 10 days ago, and one of the first things they asked is, how are you managing pain? What are you offering your patients? They want to know that you're offering non-opiate options. Things like non-drug treatments, things that will distract patients, music, anything like that. Physiotherapy should be considered other than opiates. Now, non-steroidal anti-inflammatory drugs, which you probably know as things like Motrin, Aleve, some of these are over-the-counter. These are products that could be used in place of some of the serious opiates, but they do have side effects, and you have to be very careful with them. They do cause bleeding, they have kidney toxicity, and they can have cardiovascular events. Let me just give you a personal example. I have a bad right knee, and my orthopedist put me on a non-steroidal anti-inflammatory because he said to me, I can give you an opiate. I said, I don't want an opiate. I said, I don't need an opiate for a chronic pain because that puts me into a very strong possibility of getting addicted to the drug, and I can't have that, particularly not in my line of work. It's not possible for me to use an opiate. So he put me on an NSAID called meloxicam, which you might know under the name of Mobic, and it worked fine. It was once a day. It really knocked the pain out. Yeah, but it totally wiped out my entire blood pressure regimen, and my blood pressure went up 40 points in less than 3 days. And my private physician said, what did you do? And I said, well, I started this with my orthopedist. And he says, well, get off of it. He says, you can't. I said, you may have no pain in the knee, but you're going to be dead from a cardiovascular event if you don't get off of it. And it was really a very serious type of event. I mean, yeah, I felt better, but blood pressure you don't feel that much until you have a major stroke or something. Now, neuropathic pain can be, and this is the kind of pain that diabetics sometimes get, peripheral neuropathy, things like that, pinching in the fingers, the feet, and things like that. That's that type of pain. There are other ways to treat it. And the tricyclic, which is an older type of antidepressant, the problem with that is the tricyclic antidepressants are not good choices for elderly men, because their side effect is a technical term called benign prostatic hyperplasia. It's urinary retention. So you may solve one problem and create another and not even know it, because I've actually seen that happen, where a patient was given one of these tricyclics to solve one issue, and then they were diagnosed as having benign prostatic hyperplasia when it really was an adverse reaction to the drug. And they started treating him for the adverse reaction as if it was a disease state. And when I finally got there to review the profile, I said, get this gentleman off this product, and 2 weeks later, that benign prostatic hyperplasia went away. So you don't underestimate drug interactions. They really can have an effect. Now, some of these others can also be used in neuropathic pain, but there's a cost for everything. The opiates should never be used unless there's a last resort. And I'm not saying they don't have a role in chronic pain. Acute pain is something different. Acute pain is something when you know that you're going to be on it for a short period of time. You have dental surgery and they yank out, 4 of your wisdom teeth at the same time. They could give you, OxyContin for a couple of days. You're not going to become addicted to it. But if if you have a lower back pain and you slowly are on Percocet and you start going into OxyContin and it gets 2 months, 3 months, eventually you'll become addicted to it and you'll become drug seeking. And that's the problem. These drugs should never be used for chronic pain, because that is a major problem. And that's how the country got into this mess, where we actually now have more people dying of overdoses, and of course from prescription drug abuse. And everybody probably knows somebody who's got, years ago it used to be, that wasn't the kind of people that you knew, but now it's all over. I mean, now we've accepted the fact that this is really a disease and that we need to treat it as such, and the number of people that present to our emergency room with overdoses that we have to treat with the reversal agent is very common. It's less so here, but in the Midwest it was really an epidemic. And it's only now that we're trying to hang on to this, and the problem is these drugs are very effective, particularly for cancer pain. Now, if you're treating somebody for cancer and they're terminal, it really doesn't make a difference whether they get addicted or not. You really just want to make them comfortable. I think we have an obligation to do that. But now, with all these government agencies suddenly cracking down on everything under the sun, it's going to make the people who absolutely need these drugs just to get through the day, it becomes more and more difficult for them to get what they need because of the fact that these drugs have been abused. And that's unfortunate. So managing chronic pain. All right, first of all, you never take anybody else's pain medication. Totally inappropriate. Don't adjust your own doses. You take the medication only as it is prescribed. There is, just to give you some of the things that we have to do now. When a physician writes for an opiate, they have to look into the state's system. There's a state system called iStop. They look into the state software system to see if the person in front of them, when was the last time they filled that prescription? Because you have a lot of people who are what we call frequent flyers. They go from drugstore to drugstore to drugstore to fill the prescription. And you may have given them a prescription for a month's supply, and all of a sudden they're back 7 days later. And the doctor has to look into the iStop program. The pharmacist can look in the program if they feel that they need to do it. Our pharmacists and our retail store always look in the iStop program because we don't want to be put in a position where we're literally helping an individual in the wrong possible way. These kind of people really need to they need to get into a program and they need to get some sort of guidance. We're not going to make a judgment call, but we need to get these people into a program where they get some help. Now, you don't consume alcohol with opiates. You got 2 CNS depressants. Opiates are already a depressant. You put alcohol in combination with that, and all of a sudden you've got something that could become a lethal cocktail. You don't mix sleep and anti-anxiety medications, particularly what we would call the benzodiazepines, the Valium-like drugs. They, again, have the same type of problem. Inform your provider about any of the drugs that you're taking over the counter. Believe it or not, the cough syrups that most of us probably think are relatively benign, you know the cough syrups that have DM in it, dextromethorphan, as a cough suppressant? Well, if you take enough dextromethorphan, particularly if you drink the entire bottle, it mimics some of the effect of the opiates. And believe me, there are people out there who, they're almost like, I have literally been called by a patient in the hospital who actually was literally pretending to be a doctor, asking me about what was available on the formulary. Some of them know pharmacology better than the physicians. Really. And I kind of got a little wise after a while when this discussion kept going on, and I said, like, wait a minute, you know, I said, where are you? And then she hung up on me. But some of them are really pretty good. They know exactly what they can do. That if you take Robitussin DM, you take a teaspoonful, that's good for your cough. You take the entire bottle, it gives you a buzz. Keep track of your medications. That's why I brought some of these. I'd use these myself because there are times when I forget whether I actually took something. You know, you get distracted, and then I go back there and I say, like, or I think I took it, and I look at it and say, wait a minute, they're still there. Now, luckily, I only have to take all my medications at one time in a day. If I had to take things 3 or 4 times in a day, I know I'd probably not be the greatest person in terms of compliance. It's too easy for me to get distracted. I know that. And I feel very bad for probably the person who needs the most sympathy is the HIV patient who is taking enormous amounts of meds per day and has to remember to take them all the time. So there actually are pill cassettes that are actually designed for multiple times per day. They even have some that have buzzers and beepers on them, and there are patients who are in assisted living who really can't remember to take their meds. So now you have these blister packs that can be put together where everything you take at 10 o'clock is under one blister, everything you take at 2 o'clock is at another blister. People are trying to do the best they can to get people to take the medication. Because if you don't take the medication, you're not going to get the benefits of it. It's just not going to happen. So keep your medications in a safe and secure place. Now, why do I say that? Because the highest incidence of children getting poisoned is in their grandparents' house, because the grandparents are doing the babysitting and their homes are not necessarily kid-proof. So that's what's happening. I mean, if you, everybody know what the ferrous sulfate tablets look like? They're either green or they're red, right? They look like M&Ms. Kids are really attracted to that. And for a while, you used to get them in these bottles. Well, you couldn't get them after a while in bottles because the FDA made the manufacturers put them in these little blister packs. Because the reason was that kids could get into that child-proof container better than you could, but getting that blister pack open, they would lose interest before they would get to the point where they would swallow a lethal amount. Like that St. Joseph's baby aspirin, which only has a certain number in it, that number is the amount that would kill a 2-year-old child. That's what that number is. That's why it's only that many. There's a reason for that. Dispose of unused medications. Now, the hospital is going to be putting in a disposal site in the lobby in about 2 months. Now, I gave, he has a list of all the pharmacies in this area that accept drugs for disposal. If you don't need the drugs anymore, get rid of them. You know, don't be tempted to think, well, I'll use them again sometime later, particularly if they're antibiotics. It's not a good thing to do. It's definitely not a good thing to do. Get rid of the medication. There's no way that you can recycle them or anything like that because that's against the law. If it's an opiate or anything, there are proper ways to dispose of these things. You don't want to keep this kind of stuff. And first of all, when you store them, don't store them in the medicine cabinet. The medicine cabinet, even though it's called medicine cabinet, where is it? It's in the bathroom, right? Humidity is the worst place to store drugs because it degrades the drugs. That's absolutely, it should be a dry place. Dry and secure. Maybe a high kitchen cabinet where no kid can get at it. So definitely don't use your medicine cabinet. And inform your provider of any side effects that you experience. When you go to the doctor, you get a prescription. If your doctor is able to give you 10 or 15 minutes, that's probably a lot nowadays. Okay, they're going to give you a prescription. They're going to assume when you come back the next time that you filled that prescription. Unless you tell them you didn't. And there may be reasons why you didn't. You couldn't afford it, whatever it was, and we'll get to some of those. But they're going to make an assumption that you filled that prescription. If you had an adverse side effect, you got to tell them. Because if something happened within a week or so of when you got the prescription, it's very likely it was that new product that you got. Now, hypertension. There's some new guidelines. I'm not going to spend too much time on this. The guidelines changed a little bit. The focus has been more on trying to promote healthy lifestyle. But what it really basically is saying that as the blood pressure goes up, you add drugs. So if your blood pressure is anywhere from 140 over 90 or greater, you're going to probably add at least 2 medications to try to control it. And one thing you should, when you go to your physician, you need to walk out of that door knowing why he gave you those prescriptions. You know, really, you should not be going to your pharmacist and saying, "What is this for?" Your doctor should have told you this, or you should have asked, because really you should have some inkling about why you're taking these products. Because if you ask a pharmacist, well, what is this for? They're drugs. Drugs are used for a lot of things. And a pharmacist is playing a guessing game to a certain extent because he doesn't know everything about you. Your physician does. Because drugs are used for multiple purposes. But you should really not walk out of that doctor's office without knowing why they gave you that prescription. Now, let's talk a little bit about medical marijuana. New York State is allowing medical marijuana. Now, there are some medical marijuana dispensaries. They don't necessarily, New York State does not yet, now there's a difference between medical marijuana and grass. Though I've had patients come into the hospital with a bag full of grass, believe me. And, you know, the medical marijuana is a couple of drugs that are actually dispensed by a marijuana dispensary and used for certain indications. Most of the research on marijuana for treating all of these different type of illnesses, you know, there isn't that much research, and there's lots of reasons for this. Marijuana is what's considered a Schedule I drug. Now, a Schedule I drug by the DEA is a drug that's considered an illicit drug. Now, very few people can do clinical trials on an illicit drug. It's very hard to get the approval of the government to do clinical trials on what is an illegal drug. Now, when the government finally decides to consider marijuana as treatment, because it's still considered illegal from a federal point of view. Now, a lot of the states are allowing it, but a lot of the uses of medical marijuana is really anecdotal. I'm not saying it doesn't work, but it is a hallucinogen, and you have to start thinking, since we don't allow people to drive under the influence of alcohol, that's a drug, are we going to let people drive under the influence of marijuana? There could be a lot of ramifications for this if we don't do this right. There are people who are looking at this as a potential cash cow from a tax point of view for New York State and a lot of the states, but there are also some negative ramifications here. Yet there are some very positive evidence that for people who have chemotherapy, and the chemotherapy drugs have incredible potential for nausea and vomiting. People who have wasting syndrome, there's no doubt that for those two uses, medical marijuana definitely has positive effects. The rest of them, there's some people say about chronic pain, but it's never been proven. So a lot of research has to be done on this. So let's talk a little bit about why people don't take their medication. Probably about 1/3 to 40% of the people in the United States don't take their medication after a couple of months. Now, why is that? Well, it could be too costly. Drugs are extremely expensive. There are generic drugs, and generics are still relatively flat, but anything new on the market is not going to be cheap. There's a hepatitis C is a condition that probably will put you in the hospital pretty much 4 or 5 times a year for the rest of your life. There's a drug that's has been marketed now that literally can give you a cure in about 4 or 5 months. It costs $84,000 a month. Now, from the government's point of view, that might be cheap if you look at the entire length of that person's life. From an insurance company point of view, they may not think like that. But products out there, I mean, some of the new products are incredibly expensive. But, all right, so they're not generic. The copay alone could stop a lot of people. I know that the insulins have gone through the roof to the point where diabetics are making terrible choices about what they need. And some of that has to be corrected. Cultural beliefs about medications. There are people who don't necessarily believe medications are going to necessarily... It's a cult. We're living in Queens. Queens is the most multicultural, multilingual county in all the United States. Half the inhabitants of Queens were not born here, they're foreign born. They bring with them a lot of culture, a tremendous amount of things that benefit everyone, but they also bring with them a lot of myths, beliefs that don't necessarily match Western medicine. So that's also a problem. Then you have drug therapy, complex drug instructions. I mean, I have looked at somebody who's been on Coumadin, and I've seen the instructions, and the doctor wrote 5 milligrams on Monday, Wednesday, and Friday, 2.5 milligrams on Tuesday and Thursday, and I'm saying, like, you really think the patient's going to remember this? I said, it's really not going to, if you have instructions that complex, it's really probably not going to work. You have to keep it simple. So, and yeah, people have to remember that. Dietary restrictions, frequency of administration. Now, if you have high blood pressure, my grandmother lived to be 99, and she had high blood pressure. And I said to her, well, When do you take your high blood pressure? When I feel that I have high blood pressure. I said, and when is that? I said, you're going to wait for a stroke? I mean, high blood pressure is one of these diseases that you don't know about until it's too late. You're not necessarily, unless you get a piercing headache, at that point it's really too late. So the patient doesn't see the symptoms. The patient and the doctor have a communication failure. That's you walking out the door not knowing what the prescription is for. The healthcare system, where the medication coverage changes. How often does your insurance change now? Practically every year, right? So you never know what's covered anymore. And that's another problem. So what can you do if you can't afford your medication? What are your options? Well, there are manufacturers' patient assistance programs. Every single manufacturer offers a patient assistance program. The problem with them, they're sometimes very difficult to navigate, and they require a lot of provider input. Now, you can go to this one here, needymeds.org, and there's others like that, where they try to really help people out. They can do most of the legwork for you if you're in a situation where you desperately need a medication and you can't afford it, your insurance company won't pay for it, things like that. They may be able to help you get it. So there are some options out there. So there's definitely some things that you can do. And what I did bring also is I brought this. One of the things that's critically important, you see this? You got to know what you're taking. If you end up in our emergency room, that doctor who's treating you has no idea about your medications or anything. You may not even be conscious when you get there. So get your meds on this list, fold it up like this, and keep it someplace that either whoever brings you in, your caregiver, so that, and keep it up to date. That really helps you. Because it's critically important that they know what medications you're on, so that when they have to deal with you in an emergency setting, that they can actually make an informed decision on what your medications are. That they don't actually prescribe something that interacts with what you've got. So hopefully I haven't taken up too much of your time. I do have a short little video that maybe we could show the group. It's about 2 minutes.
Not 100% sure it's going to work.
Move in closer if you want.
It should be.
How much did
Avoid Dr. Google.
Yeah. I don't have it, yeah.
Well, I have it actually on my drive.
Oh, you do? Okay. I was just,
Yeah.
Oh,
Yeah,
okay.
just go to the drive.
Go ahead. This I'm sorry. I thought you were.
No, it's all right. No, I got it on the drive. Okay, let's see.
At the bottom.
Right here.
Click on this. That's the.
Okay, where are we?
Removal disc. These are all pictures.
There we are.